Greetings, everyone. Long time no see. 2.0. Thank you for sticking with me. I appreciate it. I'll have you know I don't prefer doing 4 hours of lecture. So if I get a little tongue twisted, allow me some grace. It is more difficult than you might think. It sounds silly, like talking is like a physically draining activity, but the vocal muscles can be a little worn out after that time. So you'll have to, I'll apologize for any mistakes I make. One time someone asked, does your wife watch your videos at all? And I said, no, she can't stand listening to me at home. Am I blurry? Try cleaning off my lens a little bit for some sort of cloth device. Some microfiber around here somewhere. Pardon my noise. Oh, not there. Perhaps my physical form is starting to dissociate from talking for so long. Who knows? I know it's been about a week, but if you have any questions, feel free to post them up. Probably do some more drawings today just to illustrate some points. Oh, I wasn't there for the meeting yesterday with Dr. Butler. Anything interesting there? I'm probably more out of the loop than you guys are at this point. Well, that's good. Hopefully there'll be something fun to do with spring break. Maybe like hiking out in the wilderness by yourself, perhaps. Oh my goodness. At least until further notice. Yeah, man. Oh, yes, I have played Skyrim quite a bit. Probably have done like 2 or 3 full playthroughs in my day. That was back in, I'm trying to think what year that came out. I was probably in Fellowship when that first came out, and so I remember spending a lot of time playing that. Yeah, I'm hoping we can do some in-person lectures. That would be fantastic. Yeah, I don't want to talk about Kerbal Space Program because I think that is by far my desert island game. If I had to be stuck somewhere and I can only play one game the rest of my life, it might be Kerbal, I think. I'm not sure my play time is. I think I'm close to like 400 hours, so if that makes me sound a little sad, that is what it is. But yeah, maybe I'll do a Kerbal stream one of these days or something. I'll record the Kahoot while trying to play Kerbal at the same time, and that will make for an interesting video. And then Kerbal Space Program 2 will hopefully be out like next year, and that will be fantastic. I'll probably have to take a sabbatical for a few months. All right, let's get started here. All right. Let us see. Nope, no tabletops for me. I never got into that, unfortunately. I grew up in a pretty backwoods sort of town, so there really wasn't much of much people that played that. So convert me, don't worry. I'm good. I have enough going on as it is. A great DM. Professor Gerke's been trying to get me into that since he started working with us, and just has not panned out. So We'll see if you have any more luck. Anywho, let us get back into the topic at hand. I mean, like, really, if D&D is, I mean, there's a lot of stats that go into that, and talk about random chance, perfect segue into biostatistics. Let's talk about some of those statistical tests we can run into when evaluating some of our stats here. So basically what I'm going to do with this lecture is talk about some of the common statistical tests that you'll see performed in the literature. And so first off, I want to talk about like distribution. So if you were to look at like, say, a group of individuals and see like when certain things happen, for instance, in this example here, this is actually one looking at firefighters. And again, it's not always a super upbeat topic, but talking about death amongst firefighters. And so they were actually curious. They were looking at trying to investigate why heart disease was sort of the most frequent cause of on-duty death amongst firefighters. And they're looking to see if these deaths were like more likely to occur when they were actually fighting fires versus if it was during just any random point during the daytime. So I wanted to see if there was an association there. And so when you look at this, and I'll show you some numbers here in a second, but when you're trying to compare like what you would expect an observation would be versus what the actual distribution would be, you can compare those two together. And if they're really significantly different, they're very different from one another, you can run a test to see like, is that difference due to chance alone, or is it maybe there's something actually there, there's some kind of influence happening there. So for this sort of situation, the null hypothesis would basically be that the firefighting has nothing to do with when these firefighters are dying of heart disease. It happens just completely randomly throughout the day. They could be training, they could be, sleeping, on shift, or whatever the case may be. It happens randomly. And what we're testing for is to see, is the distribution that we're finding, is it statistically significantly different than if it was just happening at random, okay? And we can actually break that down based off of the percentage of time they're actually doing these different tasks here. And so they estimated that it was about 2% of the time that these firefighters were actually fighting fires, right? So again, a lot of what firefighters do is not necessarily actively putting out fires. And so they were looking at it. And these are what these tables will frequently look like. Basically, they have the different duties the firefighters might be performing, whether it's fire suppression, which is what they're really interested in, alarm responses, physical training, and then other duties. And then you see the actual number of observed deaths. So this is what actually happened. There's a total of 449 that they were looking at. So it's probably a pretty large group of firefighters they're looking at. And then they looked at what would be expected, because if you actually broke down their day in terms of what they're doing, they spend about 2% of the time fighting fires, 16% responding to alarms, 8% doing physical training, and then like the other 74% like, I don't know, lifting weights or sleeping or just being prepared for a fire to actually happen there. And so if there's no association between when they were dying versus what they were doing, and then it just happened randomly throughout the day, then you would expect that 2% of the deaths would happen during fighting fires. You'd expect 16% to happen during alarm responses and so on and so forth, right? So they're looking to compare the difference between what was observed versus what would be expected. And as you can see here, if you look at it, wow, that's a whole lot of firefighters are dying of heart disease while fighting fires versus what you would have expected. And you can run a test on this, and then you can get an actual p-value, right? And so similarly as before, what we can say is if we have a very low p-value, then we're saying that the difference that we're finding here is very unlikely to be due to just chance alone, right? There's something that's happening here. Perhaps when they're fighting fires, they're being exposed to toxic gases that are depriving the heart of oxygen. They're dying because of that, right? Or something's going on. If they have a high p-value, say greater than 0.05, then they could not reject that null hypothesis and say, well, these difference, they could be seen with just chance alone. Maybe it happens 10% of the time that you would see results like this. So how they actually calculate that out is by looking at the actual observed, and then based off the numbers there, they can actually calculate what the expected values would be. And so they kind of go through these complicated tables here, and I'll show you what the math looks like. But this is called a chi-square goodness of fit test. And again, the main thing is comparing an observed frequency versus what the expected frequency would be if it was completely random, okay? And the nice thing about this is you could do this with you could do it with nominal variables, you could do it with ordinal variables. You don't have to have continuous variables being done here. So for instance, I could look at males versus females and what type of car they drive, right? Those are all nominal variables. there's no magnitude of differences between them, right? So I could say, you know, Honda Accord versus Subaru versus, you know, Chevy, whatever the case may be, all these nominal variables, and see what the actual observations are versus what I would expect to see if it was completely random. And again, a low p-value would say that this differences that we're seeing is unlikely to be due to chance alone. We can reject that null hypothesis, and there is a real difference here. More firefighters are dying fighting fires than any other time. Again, it's not just random, okay? So anyway, so when looking at that, it's basically just kind of restating what I went ahead and said, is that null hypothesis means there's no differences between observed and expected. And then if it's a low p-value, less than 0.05, then we can reject that and say, yeah, there are quite a large number of people dying during while they're fighting fires, and this is unlikely to be due to chance alone. High p-value says we can't reject that null hypothesis, and this is likely an observed difference. Could be due to chance, you know. And again, it could be a type 2 error. Maybe we're saying we're not rejecting the null hypothesis when we should have, but we can't say that based off the data that you have there, okay? And again, looking at the observed values, this is how you would actually calculate it. Basically, you could look at it as like whether the person has disease or not disease. Or as the case here, if they were dead versus not dead, and then looking at the exposure. So these categories could be like, you know, fighting fires, doing other stuff. This is generally how these tables are sort of broken up. So disease versus no disease, and then exposure versus no exposure. So kind of break it up into those nominal sort of categories, or it could be ordinal, just depending on how you want to run it. And then how you actually figure out the math for the expected values. I'm not going to have you do this on the test. I just wanted to show you how they figured this out based off of what the observed values are. And they can use those totals in order to figure out what the expected would be if it was random, okay? Again, don't worry about figuring all this out. It just has to do with how the tables are broken down in columns and rows and whatnot. Okay, so you'll see that occasionally, you know, that's more with observational or more with nominal and ordinal data. You may see tables like that being done, but clinically it's not done super frequently in like terms of medical literature. Let's look at how we can compare proportions, right? And in order to do that, we would need continuous variables. And so we can do that here. We're going to talk about our prospective and then experimental studies, okay? So talk about some lingo here at first to sort of get us on, you know, even playing ground in terms of talking about these types of studies here. We're talking about things like cross-sectional studies, prospective, experimental, and retrospective studies. Some of you may already have some idea of what these mean, which is great. This will just be a bit of a review here. So the next thing we want to figure out, let's ask a question. Does exposure to a risk factor cause disease? Does being exposed to asbestos cause mesothelioma? Does smoking cause cancer? Does having a sedentary lifestyle cause diabetes, right? These are different things that we can figure out based off of risk factors and then whether or not the person got the disease state. And there's gonna be a couple different ways that we can look at that based off the type of study we want to do. A couple terms we need to know, one of which is incidence. That is going to be the rate of new cases of a disease. If I took 100 people and I followed them for an outcome over a year, and 10 people out of that group of 100 got the condition, the outcome, then the incidence will be 10% over that year, okay? We'll get more into these topics when we get into the epidemiology section later on, but I want you to at least have some idea of what the definitions are here. So incidence is new cases over a period of time. Prevalence, though, is more like a snapshot. It's more like looking at a fraction of a group at one particular time that has that disease. If I took every single PA student at Nova Orlando and I got the proportion of those people who have stress-induced ulcers after their OSCEs and farm tests and cardio tests, that would be the prevalence. If it was 10%, you know, 6 out of the 62 of you or so, roughly that, you would see that would be 10% prevalence, 9% prevalence, whatever. So there's a difference there between incidence and prevalence. Prevalence is like how many people have the outcome at this time right now. Incidence is new cases of an outcome over a period of time to be defined, right? So that can influence some of the types of studies we're going to look at. So for instance, you can do a cross-sectional study, right? So this is where you can take a single sample of subjects. You can select it whether, without regard either to like the disease or the risk factor. And basically you can then divide it up into two groups based off of previous exposure to the risk factor. So you could take a group of people, 100 people, say smokers versus non-smokers, right? And then you look at the prevalence of disease compared between the two groups, prevalence of COPD or prevalence of lung cancer between the two groups, right? And again, because it's cross-sectional, you're just taking a single slice of time in order to calculate what the prevalence is. And again, it's just the number of people that have it versus the total number of people that were exposed to that risk factor, smokers or non-smokers in this situation. So, couple other types of studies you're going to run into pretty frequently includes prospective studies, or what we might call a longitudinal study. This is basically where you can select 2 or more groups of subjects. Basically, you would set it up based off of whether they have the exposure or not. So you're going to take 2 groups of people. I'm going to take 50 smokers and 50 non-smokers, and then I can follow them over time to see who has the outcome that I'm looking for, whether it's cardiovascular death or cancer or whatever the case may be. So I'm starting off current time, I'm recruiting these people based off of their risk factor, and then I follow them to see if they have the outcome. Okay, it's a prospective sort of study. You ever hear of like a cohort study? That's what I'm talking about. Notice here, I didn't make anyone start smoking. I didn't make anyone stop smoking. It's observational, right? Because I didn't do anything. I'm just grouping people based off whether or not they have this risk factor and then follow them, okay? That's going to be a little bit easier than if you were to actually do like an experimental study. This would be a case here where I could have 2 groups divided, and I can give one group treatment and the other group not, right? So that in that case, that's the exposure to a risk factor. If I have 2 groups of people with hypertension, and I give one of them new antihypertensive and the other one placebo, and then follow them to see who has cardiovascular death or something like that, that in that case, there would be an experimental study, right? And again, be able to determine, what the independent versus dependent variables are in these sort of situations there. The independent variable is going to be that exposure to the risk factor. The dependent is going to be whether or not they have the outcome that I'm interested in, okay? The other one you're going to see pretty frequently, and this is done a lot in sort of like junior research or cases where the incidence of a disease is pretty low. You can do what we call a case control study. Case control studies basically means you're going to have people grouped up based off of whether or not they have the disease in question, right? I'll show you some examples of this so it'll be a little bit more clear. But a case control says I'm starting off with like a disease where it has like a very low incidence. Let's say people who have like polio. Like not a lot of people get polio nowadays because we have pretty good vaccination strategies and things like that. So I divide people who have polio, and then I have a bunch of cases that I use, or I'm sorry, those are the cases, and then I have a bunch of people that I use as controls to compare to those cases. And usually when you're doing like a prospective study, you're kind of trying to use it as even in groups as possible. So like 50 smokers versus 50 non-smokers. In a case control study, frequently what you're going to see is you may have like maybe 10 people have the disease in question, and then you maybe have like 30 controls. So like 10 cases and 30 controls, because you can use those people to try to control for a lot of the variables that are present between those individuals. So I'd try to match up people as close as I can. So I'd have, a 30-year-old woman being compared with a disease compared to a 30-year-old woman without the disease, right? If you can make those close, you can account for a lot of those other variables that could be playing a role, that could be biasing things a little bit, right? So anyway, so basically using a case control study, I start out with whether they are a case or a control, and then I look backwards in time to see whether or not they were exposed to a risk factor. So in the case of polio, I could look backwards to see like, okay, what were the proportion of people who were vaccinated that got polio, and what were the proportion of people that got vaccinated that didn't get polio, okay? I can look between those and determine how the risk factor, being exposed to the risk factor, had an effect on the proportion of people getting the disease in the first place. So it's kind of the difference there between like a cohort study where you're dividing 2 groups based on risk factor and then following them to see whether they have the disease. Case control study, I'm starting whether or not they had the disease and then looking backwards to see whether they had exposure to a risk factor. It's a little bit different. You're going to see there's some benefits to doing a case control study, even though they're not going to be sort of the most strong studies that are out there, but they're pretty easy to do, as we'll talk about. So let's look at some examples of an experimental study. So this is a clinical trial done back in 1993. And again, you're going to see that standards kind of change over time. We talked about how nowadays you couldn't do an HIV trial where I give someone placebo because we know that leads to increased mortality and definitely worse outcomes. But this is back in the day before we really knew what was the best treatment for HIV. But let's say we went ahead and studied the effectiveness of a drug called zidovudine, which is frequently abbreviated as AZT. And we wanted to treat asymptomatic people who had HIV with normal CD4 counts. Okay, so basically these are people who had HIV but didn't really have any degree of immunocompromisation as a result of the disease progression yet. Okay, and so what they wanted to do is they wanted to compare AZT to placebo and see what were the percentage of people that went on to develop disease progression. That either being defined as they had symptoms develop or they had a drop in their CD4 count. So if someone started, developed PCP pneumonia or something, or if they had a CD4 count drop a certain level, then that would be considered disease progression. They followed them for 3 years. So this is a case here with a prospective study because they are looking, starting at time point now and then following them forward for a period of time, prospective. And then it's going to be an experimental study because they're actually introducing something to these people. So they have a group of HIV infected individuals who are asymptomatic, and so half of them will get AZT and the other half will get placebo. So it's experimental, right? And then I'm following them to see who has the disease outcome in question, which is in this case disease progression here. And so they wanted to see, does AZT reduce progression of the disease? And remember that the null hypothesis in this case here would be that it doesn't make a difference whether they got AZT or not. You would not see any difference in progression of disease. The same, be roughly the same percentage between groups. Okay. Nowadays, we know that's not going to be the case, but back then they didn't know. Okay. So this was a randomized trial, which means that to be recruited, they had to be asymptomatic people with HIV, and then they got randomized to either placebo or AZT. Okay. So that process is random. And it's called a double-blind study. Double-blind means the patients didn't know what they received, and the providers didn't know what the patients were getting. The reason why we do this is because we want to make sure that we're taking out any sort of bias or any sort of like placebo effect that could be occurring either with the patient or the providers. So for instance, if it's based off symptomatology and someone knew, like the providers knew that the patient had received active drug, they may be more likely to view that favorably and try to, maybe unconsciously or consciously skew the results to where it looks like the AZT is more effective, if that is what their, predilection is. Or could go the other way too. And so double blinding is really, really important because that's a way that we can try to take as much bias out of the process as possible. I remember when I was working at Nemours more full time, one of my responsibilities was to help out with the research pharmacy side of things, and so we did a lot of preparation for drugs in order for patients to get it. So going back to SMA, which I was talking about in the last lecture about spinal muscular atrophy, we were actually doing a study with a drug that's very similar to that Zolgensma I talked about. It's a different mechanism. Basically, it's a double-blind trial. So the patients didn't know what they were receiving. The parents of the patients didn't know what they were getting. The providers didn't know, but we knew because we had to know. In order to make the drug correctly, we need to know whether to do a placebo dose or whether to do the actual active drug there. And so it was really kind of odd because I had to go and actually deliver the drug over to the clinic to where they could actually inject it. And like they were looking for any sign in your face of like whether or not this was active drug or not. Like I was going to walk over there, like a big smile on my face and be like, hey, we got active drug here. Couldn't say it because if we broke the blinding, that could influence the results of the study and introduce bias that could invalidate the whole thing. So breach of blinding is a really huge deal in clinical studies. You never want to be responsible for breaking the blinding, okay? Anyway, so there's that, and then it's a prospective study because we're following it forward in time. We're not looking backwards in time. Anyway, so what they did was they compared this and they said, okay, let's look at AZT versus placebo. So we kind of divvied it up based off of the risk factor that we're either exposing the patient to AZT or just giving them sugar pill. And then we looked at the proportion of people who had disease progression versus no progression. Okay, so you can see here the differences. And just eyeballing it, it would look like, yeah, it seems like the AZT is definitely having a smaller proportion of people who have disease progression. But of course, my eyes are not going to be so good in order to determine trends in the data like that. I need to actually do the math, do the stats to figure out whether this is statistically significant or not. Okay. So what they found is that the disease progressed in about 16% of patients receiving AZT. You see the math there. And then for the treatment group, you're going to get 95% confidence intervals that will be included with this, right? So in this case here, the 95% confidence interval ranged anywhere between 13 to 20%. That means that if you were then to take that group of individuals and expand it out to all the people who are symptomatic with HIV and gave them AZT, disease progression would likely happen between 13 and 20% of those cases, okay? Again, that's what the 95% confidence interval is telling us. If we were to blow this out to the whole population of those people, that they'd have between 13 and 20% chance of having disease progression. Versus looking at the placebo group, it was 28% with a confidence interval range between 24 and 32. So again, you can see here there's a difference about 12%. And so we want to figure out if that difference is clinically significant, or it should certainly be clinically significant. We want to figure out if it's statistically significant to see if these differences could be just due to chance alone, or it's very likely that AZT is having a true influence here on disease progression. Okay, so looking at this, one of the things we can do is what we call attributable risk. Attributable risk is basically where you take the risk of something happening in one group and subtract it from the other group. And so basically we can say, what is the amount of risk that we can attribute to this particular intervention? Because remember, when you do a randomized trial, that the people should be very similar to one another. If they're truly randomized, they are going to be very similar in age and ethnicity and gender and comorbidities, all the stuff they try to control for to make sure that the groups are similar and that there's not any kind of undue influence or bias being introduced here. So we can say here, by looking at the differences in risk, in this case here, 12%, we can say that this decrease in risk of having disease progression, or this absolute risk reduction, is 12%. Okay, because you're taking the 28% minus 16. So I'm saying the absolute risk reduction. You've probably heard of that term before, absolute risk reduction. That's what we're doing. We're just subtracting one versus the other. This is not relative risk. That's a different thing we'll talk about a little bit later. But if you're subtracting one from the other, it's absolute risk differences. Okay. Now, you can also develop a confidence interval for that as well. And you can see here, 95% confidence interval means if I were to then expand this out to the whole population again, the absolute risk reduction I would see in the population by giving them AZT would be somewhere between 6.7 and 17.3%. And that p-value ended up coming up to be 0.001. Now, a key thing here, I don't even need the p-value to actually tell a difference, or to tell if this is statistically significant. Because if these were very similar to one another, if it was 28% minus 28%, that absolute risk reduction would be 0, right? Because my null hypothesis says AZT doesn't make a difference. And so in those cases there, the null hypothesis would be there would be a 0% risk reduction, because 28% minus 20% would be 0. So if the confidence interval includes 0, then this would be non-significant. Because it does not include 0, then I could safely say that this is a statistically significant result, and I can look at my p-value, see it's less than 0.001, so it is very unlikely that the results I'm seeing here, this difference in risk between the two groups, is due to just chance alone. There's something going on here, and likely it's the drug that we've introduced here. Could it be other bias? Sure, but it seems very likely based off the strength of the study and the study design, the methodology, that it's likely due to the AZT. Okay, so then we can assume the subjects represent the larger population of asymptomatic CD4 stable HIV-infected persons, where 95% confidence that AZT treatment will reduce progression of disease between 6.7 and 17.3%. Okay, so you can see how they can be confident in saying that based off of what they're finding here and based off the statistical significance of the results. Okay, if that doesn't make sense, let me know, right? Because I can always go back and talk about this. The helpful thing, though, is what we call number needed to treat. And so this is a really helpful number that providers like, because it kind of gives them a better real world example, or patients too, of what this means in terms of their utility of using a certain intervention. Because you can say, hey, this is going to reduce your chance of disease progression by, between 6.7 to 17.3%. The patients are not going to know what that even means. They're going to be like, well, what does that mean for me, right? What does that actually matter? What we can do, though, is develop this number needed to treat. There's also a number needed to harm. That's going to be where something like an intervention increase the risk for something happening. But here, this is number needed to treat. And what it tells us is how many patients we would have to give AZT to prevent one person from having disease progression. Okay. And basically, you just take the reciprocal of the absolute risk reduction, and it turns out it's 8.3. This means that for every 8 patients who I put on treatment for AZT, I'd prevent disease progression in one of those people. Okay, this is really helpful because it helps you to determine the efficacy of an intervention, and also if you figure out the cost of that intervention per person, it can give you an idea whether an intervention is cost effective or not. Because you can have something that makes a really big difference, but if it's so costly that it's impractical to implement, then you're never going to do it. Right, so that's when you get into the public health sort of thing there. So what you can find here is that you can find things that have large numbers needed to treat, but are very cheap, maybe good to implement, like patient education or something like that. Or if it's a very low number needed to treat, even if it's expensive, it may make a difference. If I have to treat 2 people to get 1 benefit, then that may be worth it. So it's very much a cost-benefit analysis that is run in a lot of these situations, especially when it comes to public health stuff. Okay, you can again develop a confidence interval for these numbers needed to treat. So it would go anywhere between 5.7 to about 15 people. So it's expected if I were to treat anywhere between 6 to 15 people, I should have one person not have a progression of their disease. Okay. So what do you think is better, a higher or lower number needed to treat? Well, definitely a lower one is going to be better. So if I need to treat fewer people to see benefit, that means it's more of an effective treatment, right? You don't want something that's a number needed to treat of 100, because that means I need to treat 100 patients just to see one person benefit from that. That's not great, right? Because again, you think about the numbers of patients you might be seeing out there in clinicals. You might be seeing 30 a day, or is at least one of those 30 people going to benefit from your interventions? You hope so. Hope it's probably more than that. But again, this is where these numbers come from. So there's something called relative risk we can do as well. And so this can be handy when you're trying to divide one risk by another. So in the other case of absolute risk reduction, you were subtracting one from the other. That's why it's an absolute risk reduction. Now we can talk about the relative risk between these two. Okay, so this is the ratio between two proportions, progression in the treatment group versus progression in the placebo group. In this case here, it would be 16% divided by 28%. And so you can see here it was a relative risk of 0.57. What does that mean? Basically, it means subjects treated with zidovudine or AZT were 57% as likely as placebo to have disease progression. So basically, you'd say that their relative risk is only 57%, or about a little more than half, right? Now, whereas an absolute risk reduction can have a very wide range of numbers between negative infinity to positive infinity, relative risk are always going to be between 0 and 1. Or in this case here, when it's between 0 and 1, it's going to mean that the risk has decreased. You don't really ever see a negative number here, right? But if it's between 0 and 1, it means the risk has decreased. So in this case here, it went down to 0.57, so the risk is lower. If it were to go above 1, that would mean that the risk is increased. The risk of disease progression would go up in those cases there. So, and again, I don't even need the p-value to tell me that the value here is going to be statistically significant, because the 95% confidence interval is 0.44 to 0.74. This means that the actual relative risk of disease progression when getting treatment is between 44% and 74%. When doing a relative risk, if these were the same and the null hypothesis was true, it'd be 28% divided by 28%, which would be 1. So if my 95% confidence interval for relative risk encompasses 1, then it would be non-significant. Because this does not encompass 1, because both values are less than 1, then this would be considered statistically significant. So that's a big difference there. I want you to make note of that. With a relative risk, if the confidence interval includes 0, then it's not statistically significant. For a relative risk, if the confidence interval includes 1, it's not significant. Okay? So you can repeat that if you need to, but that's an important point I want you to make sure you guys get. So anytime you're doing a relative approximation, so when we look at odds ratios too, that's also going to be important. If it includes 1, it's going to be non-significant, okay? So as I mentioned, with the p-values, start with a null hypothesis that AZT is not going to alter the probability of disease progression here. And so we're basically answering that question. If the null hypothesis is true, what is the chance that the data that we got, the actual observations we made, would be that different from the observed, or more different than that, right? Yeah, I can repeat it. So basically, if you were to have, let me show you. So let me switch over just to draw this out. So for relative risk, right? Relative risk, meaning you're dividing one thing by another. If it includes 1, it's going to be non-significant, not statistically significant, because 10 divided by 10 is 1. So if there's no difference between the two groups, then the confidence interval is going to include 1. For like absolute risk reduction, right? I should probably say, it's probably not the best way to do it. Let me type it out actually. Again, I'm trying to find new innovative ways to teach you guys. So sometimes I'm going to crash and burn a little bit here, but that's okay. Let me, things are relatively safe. So let me do my background. Oh, that's not it. Oh my goodness. I'm trying to find get my word. I'm just going to type it on a new slide here. How about that? You guys are probably like, he's the biggest dope here. Doesn't know what he's doing. All right, so just to summarize here. Summarize. So if relative risk, if the 95% CI includes 1, not significant. Okay? If the absolute risk difference, because again, then you're subtracting one by the other. If 95% includes 0, not significant. Okay, so anything where you're dividing one by another, if it includes 1, is not statistically significant. With anything where you're subtracting one thing from another, if it includes 0, then it's not statistically significant. I will show you plenty of examples of this, so don't worry if it doesn't make a whole lot of sense now. I'll show you some real life examples when you do like journal clubs and all that kind of stuff there, or a review for the test and whatnot. Okay, so don't get too hung up on that right at this moment. Anyway, so now let's look at some examples of some other types of studies. Let's compare proportions. Let's do a case control study. So those are the ones I was talking about, where you can start off with people with the disease versus no disease, and then you look backwards to see what were the odds of those people being exposed to the risk factor. In this case, it could be vaccination, it could be smoking, whatever the case you want to be. But this is a case here where we're looking at whether the cholera vaccine was effective. And so this was a case control. And again, most case control studies are retrospective. You're starting off, you have a group of people who have the disease in question. You can find controls to match those with, and then you look backwards in time to see, did they have exposure to a risk factor? In this case here, they want to know whether exposure to the vaccine was having an effect on whether or not they were having a disease or not, okay? So retrospectively, and again, this is a lot easier to do. You can do like retrospective like chart reviews and do this, relatively low cost. And again, it does not involve a lot of time. With that one we were looking at before with AZT, it took 3 years to run that study, right? It's a long time, a lot of commitment versus this. You can just do a retrospective chart review and do it in a couple months to a year, right? Just depends on how you're running it. But no direct time involved because you're not following patients. You already know what the results are. You already have the endpoints, okay? So anyways, they wanted to know whether people with cholera are less likely to have been vaccinated than those who did not get cholera, okay? Notice the difference here between like a cohort study or an experimental study where you're starting off with the risk factor and then looking to see who develops the outcome. Now we are starting with the outcome and looking backwards to see what the odds are that those people had exposure to the risk factor. Okay, so it's a little different, it's kind of a backwards way of looking at it, but can still be useful here. So what they did is they started off with 10 cases of cholera, right? And they went ahead they had a total of 43 cases of cholera. So people actually had the disease. And again, that's not a lot of people. And again, not a lot of people get cholera. So this makes sense if you're doing it with something that's a relatively low prevalence in the population. That's typically what it's done for. So you have a total of 43 cases here, and then you were then to have matching them with 172 controls. Keep in mind, typically the controls will be much larger because you want to have like 2 or 3 controls for every single case that you have, generally. So in this case here, it'd be like a 4-to-1 ratio, roughly speaking. So that way you can control for things like age and ethnicity and gender, all those different things that could be influencing the results, okay? So then of those cases, 10 of them, they look backwards in time, they saw that 10 of them had received their cholera vaccine, 33 did not. And then on the control side, they found that 94 had received the vaccine, 78 did not, okay? So one of the things you're going to find is you can't really calculate relative risk from a case control study. This is going to be a subtle distinction here I want you guys to make. When you're doing things like relative risk, you have to know the whole sample set that you were dealing with, right? So when I'm doing an experimental study and I have 100 people in a group, I know my whole population for this sample is 100 people, right? I know those are the total number of people who are at risk for developing the outcome because I'm setting up that group, right? When you're doing something like a case control study, I'm looking backwards, I don't know what the entire population, I don't have all that data, right? So I don't really know the total number of people who are at risk for developing cholera. And so instead what I can do is called odds ratios. So instead of doing a relative risk, I'm going to do what we call an odds ratio to see what were the odds of people with cholera being exposed to the vaccine versus people without cholera being exposed to the vaccine. And I can look at the odds between those two groups and come up with an odds ratio. And I'll tell you what that, kind of go into what that tells us in a moment here. Because again, cases and controls aren't even. I'm using a lot of controls against each case in order to, again, account for a lot of biases and things like that. Because I'm not dealing with a study with 1,000 people in it. It can account for a lot of bias and randomness. I'm doing like 43 cases. That's not a ton in a lot of, as you'll see with a lot of like medical research, okay? So it can't calculate incidence. I can only work with prevalences here. So that's when we get to the odds ratio, as I mentioned here. So case control studies are best summarized with the odds ratio. I'm going to bold that one because that's an important distinction here. Now, a subtle difference here between probability versus odds. Probabilities are basically the chances that an event is going to occur, the fraction of times you expect to see in the event in many trials, right? So it can range from 0 to 1. So I can expect a probability of, me flipping a coin and being heads or tails of 50%, right? I know that probability pretty easily. Instead, odds is going to be defined as the probability that the event will occur divided by the probability that the event will not occur. That sounds confusing. And basically, odds are going to be any positive number. It could be 0, but it's not going to necessarily range from 0 to 1. It can go much higher than that, okay? Probability is just a percentage, whereas odds can be infinite. It can be any positive value there. And so in order to convert probability to odds, basically we divide the probability by 1 minus that probability. I'll show you what that looks like in just a second here. So let's show you an example of probability versus odds. Let's say a horse runs 100 races and he wins 25 times. We shall name the horse Oswald. I don't know, whatever you want to name it. So here you can see the probability of him winning is 25% because he ran 100 races, and so he won 25 of them. So 25 divided by 100 is 25%. That's the probability of him winning future races, right? The odds of him winning is basically going to be the probability that we have of him winning, so 25%, divided by 1 minus that. Or in this case here, he won 1 race to every 3 losses. Okay, so 1 win to every 3 losses. I guess that should be losses, not loses. That doesn't make sense. It's a subtle distinction, but it's just know that this is what we do for case control studies when we're looking retrospectively, okay? Because again, we don't know the full population who's at risk for developing the disease in question, okay? Don't get too hung up on it. If you know just at a baseline that case control studies are using odds ratios versus prospective, experimental, or case cohort studies are using relative risk and absolute risk changes, that's good enough for me for most of my questions on the test. So anyway, what we can look here is that the results from a case control study are summarized here as odds ratios. So among the cases of cholera, we saw that the odds of being vaccinated were 10 to 33, or if you divide that out, 0.303, right? So if you go back to that thing here, the odds of the people who had cholera being vaccinated was 10 to 33, or 0.303. Okay, about a third of those patients there who got cholera were vaccinated. Okay, the odds were 0.303, I should say. Looking at here, the controls, you can see that the odds of being vaccinated was 94 to 78, or 1.205. So now what I can do is I can do an odds ratio comparing the odds of people who had cholera and their exposure to the vaccine versus people who didn't have cholera and their exposure to the vaccine, and I can get a relative odds ratio. It's kind of odds ratio there. The odds ratio would just be 0.303 divided by that 1.2, and you get 0.25. This is the money number. This is what you want to know, right? And you can get a confidence interval for that between 0.12 and 0.54. Again, because this isn't a ratio, because this does not include 1, you can say that it would be statistically significant, okay? The p-value is going to be less than 0.05, I can assure you that. So basically we can say, what we can conclude from that study is that vaccinated individuals are 25% as likely to get cholera as unvaccinated people, okay? This can show you that, yeah, the vaccine is effective. Or if this had been like a positive number, if it was greater than 1, then I can say, well, people who are vaccinated were more likely to get the disease than not. Okay. In this case here, frequently, when you're looking at like a preventative strategy, something like a vaccine, oftentimes you're just going to take the flip of that. So instead of 25%, you would just do, you could say that the vaccine is 75% effective in preventing cholera. Okay. Now, the strength of that is not as great when you're doing a case control like a retrospective study. The best type of study you could do would be to take a bunch of people, put them into 2 groups, one of which got vaccinated, the other didn't, and then you follow them for several years to see who got cholera, right? The problem with that, though, is a lot more labor intensive, time intensive, costly to do that. How long do you follow them for? How long does it take for someone to get cholera potentially? It's much more labor intensive to do a prospective experimental study like that. The benefit of odds ratios and using case control studies is that they're quick and easy to do, and they're very good for generating ideas for future prospective studies. So most ideas will start off as a case control study like this and then be used as a springboard to forming, a prospective study, for instance. So, and again, when you're looking at the odds ratio, it's going to be accompanied by a p-value. And so in this case here, I already told you it was going to be statistically significant. And sure enough, the p-value is 0.003. Okay. So the chances that this is just the differences you can see between people with cholera versus those and whether or not they got vaccinated, there's like a 0.3% chance that those differences we saw there are due to chance alone. And so it's very unlikely. So we can reject that null hypothesis and say, yeah, people with cholera were less likely to have been vaccinated than those who did not get cholera, right? Now, in this case here, they used a two-tail p-value. If you recall, we talked about one-tail versus two-tail. In this case here, two-tail would be if you didn't know which way it was going to go, if you didn't know if the vaccine was going to cause more cholera or prevent cholera. In the case there, you want to give yourself that wiggle room to go either direction. Use a two-tail test, which again is more conservative, makes it more difficult to achieve significance. But even using a two-tail test, you still found the p-value is 0.003. So you can be really assured that these results are not likely due to chance alone, and you can feel confident recommending cholera vaccine, right, if it's right for your patient. So as I mentioned, there's a lot of challenges here. The advantages of a case control study is it can be done really quickly. A lot of, during my fellowship, it was a 2-year fellowship, and a lot of the studies that people do during that time are case control studies because they're so easy to do in a relatively short period of time. My fellowship was 2 years. You have a relative short period of time to get these things put together. And so these are really good for that. So like for student projects, for fledgling ideas where you want to try to generate some hypotheses for future studies, these are really good because they're so easy to perform compared to a prospective experimental study there, right? Now the problem though is like how do you pick the right controls? So for instance, like how do you figure out who's going to be the control for all of your cases? You don't want to over control for it because sometimes you can introduce bias that way too and make it more difficult to find a difference should one be there. So sometimes that can introduce a type 2 error. But you want to control for things like gender, ethnicity, easy stuff that may have a big influence. Like especially genetic factors. You want to compare males to females because maybe there's something that could be Y related or X related depending on the type of risk factors you're looking at, especially like with heart disease and things like that, right? So how do you know when to accept the results? They're more likely to be true when the odds ratio is large, when there's a big difference in between your cases and controls there. And then if you can repeat the study with a different sample, you'll also find that can give you much more confidence in your results, especially if it makes sense biologically. I think there are a few people who suspect that if you got the cholera vaccine, you're more likely to get cholera. Is that a possibility? Maybe, but it's unlikely with our current knowledge of how vaccines work, right? Okay, so up next, what's another common thing we can do? So let's say we have two groups. We wanted to do an experimental study where we're initiating like a new antihypertensive drug, and we follow them to see what was the proportion of people that died in the treatment group versus the proportion of people that died in the control group. That will generate a mean for us, right? They'll tell us a mean number of people who died in each of those groups there. How do you compare those two means together? And that's where we're going to come up with the unpaired t-test. The t-test is super important to understand because it is used quite frequently. If you ever hear like a student's t-test, that is sometimes a name. There's a slight difference there, but the t-test is very, very important there. And so this is a weird example, but it came from a book, so I'm going to keep using it for now. Let's say we're comparing two groups of rats to one another, and we want to look at the maximum relaxation of bladder muscles. Again, not all studies are very exciting, and this one happens to be one of the more exciting ones that I've ever read. Very, very exciting stuff here. But they wanted to figure out how well the neurotransmitter norepinephrine relaxes the bladder muscle, right? And it makes sense that norepinephrine would relax it because if you're in a fight or flight response, you don't necessarily want to go pee. You want to hold on to that urine. And so typically you're going to find that will allow the bladder to relax and hold on to more urine, right? So what they wanted to do was compare young rats to old rats and see which one of those groups when exposed to norepinephrine had more bladder muscle relaxation, okay? They wanted to find, is a difference in the means there? Is it due just to chance, or is there a true difference in terms of age and their effect of norepinephrine on that muscle, right? So here's the actual values here. You can compare the two together. So this is sort of the maximum relaxation that occurred between the old rats and the young rats, right? Numbers aren't quite so important here, but the main thing to look at is you can see in terms of how the data is spread out, you can see the mean value here for the old rats and then the mean value here for the young rats. And you can compare these two means together to see, is this difference likely due to chance alone, Or is there a real difference between these groups here? Can I reject the null hypothesis that age of the rat has no effect on maximal bladder relaxation? And again, there's certain sentences you never expect yourself to be saying in your life, and that happens to be one of them. And I've said it for a few years in a row now, so I guess I shouldn't be that surprised. So using a t-test, you can compare those two groups together and come up with a p-value that shows you whether or not, what are the chances that difference you found were due to chance alone, right? And so in this case here, the p-value ended up being 0.0030, which is less than obviously than 0.05. And so I can reject that null hypothesis and say, yeah, the age likely has an effect on the differences in the means that I'm seeing here between the young versus the old rats, okay? Now, again, when you run like stats tests, you're going to find a lot of other gobbledygook that honestly doesn't affect us a whole lot clinically. Main point, though, is the other thing I want you to know is whether it's a two-tail or one-tail test. Now, we're not using two-tail tests because we have two groups of rats. It's more so of if you're not really sure which direction or which group is going to have the larger mean. Could the study have happened to where the old rats had the larger mean? I don't know, right? So if you don't know going into that, then you go ahead and use a two-tailed test. So that way you kind of cover yourself in both directions, both eventualities of one mean being larger than the other. If I was reasonably assured that the mean was going to be higher in one group versus the other, then in that case I can use what they call a one-tailed test. And again, that gives me a little bit more, it's easier to detect differences when you're using a one-tailed test. Two-tailed tests are more conservative, meaning you're more likely to make type 2 errors. Using a one-tailed test, especially if you use it inappropriately, means you might be more likely to see a type 1 error. Okay, so there's some drawbacks with either one of those cases there. And again, when looking between these two, you can see, again, the graph we showed you on the previous slide there. This graph here is just showing you the mean difference between the two. So if you took like mean B versus mean A there, and again, you can get a confidence intervals showing between that. So the mean difference, the differences in the means and the confidence interval that surrounds that, okay? So just some ways you can represent the data. So now this is also called what we call an unpaired t-test. An unpaired t-test means that the groups are completely separate from one another, right? You're not checking family members against one another. You're not doing like siblings. You're not counting the same person twice. If you're doing any of that, then you have to use a paired t-test, okay? So one of the assumptions you're going to see here is that there's independent observations. There's no relationship between the different rats in these cases here, right? So when looking at this, you can get a confidence interval associated with this t-test, and basically the mean maximum response in the old rats is 23.5 units lower than in the young rats, and that actual confidence interval for that was between 9.3 and 37.8. Now again, because I'm subtracting one mean from another, means that if they're the same, then that mean difference would be 0, right? So if the confidence interval includes 0, then I cannot reject the null hypothesis. I know my p-value is going to be greater than 0.05. Because here the confidence interval range between 9.3 to 37.8, and it's greater than 0, then I can say with statistical significance that there is a difference between these groups here, and I can reject that null hypothesis that age has no effect on the maximal bladder relaxation in response to norepinephrine, okay? In this case here, I'm doing a two-tailed p-value, two-tailed test, and so the p-value they got was 0.003. So again, very unlikely to be due to chance alone. Okay. Now, what are the assumptions when I'm doing an unpaired t-test? Well, basically these have to be random or representative samples. You don't want any sort of biasing in your samples to where you're maybe skewing the results one way or the other. They need to be independent observations. Data should be collected accurately, obviously. And again, with you're doing a t-test like this, you're assuming the data is distributed in a Gaussian manner. The population comes from a Gaussian distribution or normally distributed data set. Again, if you're violating this, you have to use a different test. And we'll talk about what those tests are a little bit later on. And again, the two populations, they can have the same standard deviation, even if the means are distinctly different from one another. Again, standard deviation just comes into the variability in the data around that mean there. So don't worry too much about comparing standard deviations between the groups there. It just has to do with the individual sample you're dealing with. Now, what if I want to compare two paired groups to one another, right? So let's say I wanted to do like a pre-post kind of study where maybe I did one kind of therapy for a patient and then I did a washout period and then I had them, the same patient, get exposed to a different treatment. I could then compare that person pre and post, and that would now be considered a paired test. Or if I wanted to do an experiment on siblings that share genetic traits, that would be an example of a paired test because the groups are not independent. Okay. So when we use a special test here, so a paired t-test is then going to compare two matched or paired groups when the outcome is continuous. So kind of like if I was to look at the same group of rats under two different treatments, that would be considered to be a paired t-test. It's important to make sure you don't use paired t-tests on unpaired data and vice versa, because you can run some errors with type 1 and type 2 errors there. Okay, so and again, when you're going to run into this, their design, so the same patients or the experimental preparation are measured before and after on intervention. So that's why you'll see, like, for instance, they make it 6 weeks of a treatment of a drug, measure whatever outcomes they're looking at, then they'll give them like 2 or 3 weeks for the drug to wash out, and then they'll do a different drug, or they'll do a different dose or something like that. And that way they can compare the same person, because again, that same person, there's a lot less variability between that same person getting 2 different treatments than 2 randomly different people. Okay. So there's more power to detect differences in a paired test. And if you were to then use that same test for unpaired data, it's likely to show type 1 error. So that's why we don't want to do that. So if you have paired data, use a paired t-test. If you have unpaired data, have independent observations, use an unpaired t-test. Pretty straightforward. So as I mentioned, when the subjects are matched or paired, special paired tests should be used as an example. I talked about the paired t-test there. I'm trying to think of some other examples when you see that. It's like twins and siblings, and then like a pre-post kind of situation, or kind of the most common paired sort of data sets you're going to run into. Or actually, here's another good one too. The same subject having a measurement performed via 2 different methods. So you can imagine if I were doing like comparisons of rectal temperatures versus temporal temperatures, and I was to do that on the same individual, right? So that's going to have more power to detect a difference, because I'm doing it on the same person as opposed to if I was doing on just random sampling of people. So more power to detect difference when using paired test here. Okay, here's another example. Here's an actual case where going back all the way to 1876, so the most cutting edge medical research here. They're looking, so Charles Darwin was comparing growth of plants from seeds that were self-fertilized versus seeds that were cross-fertilized. So again, you can see how there's a relationship between these plants here. And so the seeds were paired to control for changes in soil temperature and sunlight, right? So these are things you do to control different variables to make sure that it's even Steven amongst the groups, that does not introduce any kind of differences, different sources of bias, essentially. So what we can look at here is the difference between cross-fertilized versus self-fertilized. Again, this is not probably the most relevant clinical example, but I think at least illustrates the point here. And so you can see the differences amongst these, right? So anyway, what you can look at is you can actually look at the mean value here. You can look at the spread of the data as well. And you can actually even show this in a different way. For instance, showing the mean difference in height and then the standard error of the mean here. Notice this is not a confidence interval, right? So you don't want to make sure you know what the legend is for the graphs. Make sure you know what the values you're looking at are. If you see like crossbars and things like that. But again, what they notice here, they did a paired t-test, and so they end up coming with a p-value of 0.0497. So was it statistically significantly different? Yes, but just barely, so it would be one thing you want to note with that. And again, they did a two-tail value because they didn't know which group was going to have the larger mean there between the two. So again, just to give you an example why we would do a paired t-test versus an unpaired t-test. So how do we look at the results here? Again, we can use a confidence interval. If you're looking at a mean differences between two groups, again, if the confidence interval includes 0, then it's not statistically significant. And what you can actually see here is that the confidence interval for this group's range between 0.003639 inches, which is very close to 0, all the way to 5.23 inches. So again, still considered statistically significant, but just barely, because if that was actually 0, then it would not be considered statistically significant. Okay. Again, especially when you're doing like small data sets too, that can really cause your confidence intervals to be quite large. The best way to shrink down confidence intervals is to go with a bigger sample set. More difficult logistically, but it's easy from a stat standpoint. And so again, p-value here 0.0497, just barely clinically or statistically significant. Something to note, maybe if you repeated the experiment, it would be greater than 0.05. Who's to say? But that's why repeat studies is usually the best means of testing the scientific validity of one study. And again, we'd use a two-tail test because we weren't sure which one's going to have the larger mean between the two different plants. Okay. So that's an introduction to t-tests. We'll talk more about those, especially as they relate to actual medical literature when we get into our journal clubs and things like that. Now I want to talk about correlation, which I'm sure most people know does not equal causation, but how do we explore the concept of correlation? So basically, we want to say correlation is going to be the association between any two continuous variables. And we can actually demonstrate this amount of correlation with a coefficient. That's going to be R. So this R value is going to be important when we're talking about correlation between two different values. So here's an example. This is a study done back by Borkman in '93, which is a great last name, but they wanted to look at, they're hypothesizing that the lipid composition of the skeletal muscle cell membranes was affecting the sensitivity of the muscle for insulin. So basically looking at the fatty acid content between different individuals and looking at their insulin sensitivity for that muscle. Okay. Again, maybe this was some precursor for some diabetes research and things like that, but this is the study they were doing. So they determined insulin sensitivity for 13 healthy men. And so they infused insulin at a standard rate. So they just give an insulin infusion. And then they figured out how much glucose they needed to infuse in order to get a constant blood sugar level. Okay. So the insulin was the same between everyone, but the amount of sugar it needed to infuse in order to keep it steady was different between the two, right? So in this case here, we're going to see that they also did a muscle biopsy to determine the fatty acid composition for those individuals to compare that to the glucose level, right? The insulin sensitivity they could calculate. And so in this case here, the independent variable is going to be their fatty acid content, especially these polyunsaturated fatty acid contents that were between 20 and 22 carbon atoms long, okay? They wanted to compare the insulin sensitivity based off of that. So the independent variable being the fatty acid content, they want to compare that to insulin sensitivity as the dependent variable, okay? So both variables are going to have scatter, right? Because again, not everything is going to be exactly correlating on a nice straight line, as we'll see there, because of natural variability in biology. If you were just to look at the mean insulin sensitivity amongst all those individuals, there's a really huge amount of variability, right? You can see here is the mean insulin sensitivity is 284. It ranged anywhere, standard deviation was 114. I mean, it's huge, it's like half that value there. A lot of scatter there. And so they knew there was going to be a lot of variability, and they wanted to find reasons for why there was such variability in insulin sensitivity between these healthy men. And so that's why they wanted to investigate this fatty acid content. What they found was much less variable, and they actually compared those two together. And I'll show you what the graph looks like in just a moment. And so what they found is that these two did correlate with one another. They had a degree of covariation. So let me show you what that looks like. Here's the actual mean, or the actual data, raw data, which again is not super impressive just looking at it like this. But if you were to actually plot this on a line, where you look at the percentage of having this fatty acid of carbon link 20 to 22, compared to the insulin sensitivity, what do you kind of notice? Well, you notice as one goes up, so does the other. That's correlation, basically. This is a positive correlation, where you see as one goes up, the other does as well. Notice it's not a straight line, so it's not perfect. There's definitely some degree of biological variability. But what we want to see is that degree of correlation to one another is what that R value is going to be. Okay, so let me show you some examples of what that will look like. When you're looking at that direction and magnitude, you correlate that, or you have a correlation coefficient called R, and it can range from -1 to 1. Okay. And so -1 would end up being like a inverse relationship versus 1 being a positive relationship there. And so I'll show you what those look like in just a second here. So the coefficient is 0, then that means the two variables did not vary at all together. It means that one had no relationship on the other. The value of the fatty acid content could go up, but then insulin sensitivity could go down, and vice versa. If it's 0, there's no relationship between the two variables. They don't covary at all, okay? If they're positive, that means as one goes up, the other one does as well. And if it's negative, it means as one value goes up, the other one goes down. Okay? The graph will be clear on that in a second here. And that's why R goes from 1 to -1. If it's 1, it's going to be a straight line in either direction. In this example here, it ended up being 0.77. Okay? So here's some comparisons of what these different plots would look like at various R values. If you notice here on the left, here is what -1 would look like. So exactly as one value increases on the x-axis, notice it's going down on the y-axis. This is an inverse relationship between these two, right? So negative correlation coefficient. Notice here as you get closer and closer to 0, the scatter gets much more random, right? In this case here, there's no correlation between y and x. They just kind of go any direction willy-nilly, right? No relationship here. As you start to get a positive R value, you notice here it's going to get closer and closer to a straight line, to where if it's 1, that means exactly as one goes up, the other one goes up exactly like this, okay? There's no scatter in the data. It's a straight line. So rarely do you come up with R values of -1 and 1. You just come somewhere in between. So in the case that we were looking at with insulin sensitivity and all that, and it being like 0.77, so it looked pretty much like this, and that kind of made sense based on what you look like. Because it's easy to look at the graph and say, yeah, it looks like they correlate with one another. But it's better to have the values to actually tell you what that means. And again, we can get confidence intervals for these as well, because we did it in 13 men. That doesn't mean that it's going to be able to be applied to all men that are out there. So we can use a confidence interval that gives us an idea of what the actual correlation coefficient would be if you were to then expand that out to, say, all men in the US, for instance. And in this case here, range between 0.38 to 0.93. So it's pretty wide, which makes sense because you're dealing with a pretty small sample set. But you want to find out if this is going to be significant or not, right? How do you tell, just based off the confidence interval, this is going to be statistically significant? Well, in the case of here, if you were to assume the null hypothesis being that there's no relationship, there's no correlation between the two variables, you would say that the R value would be 0. But because the R value is, and the confidence interval does not include 0, then you can reject that null hypothesis and say, yeah, there is covariation between the two variables. As one goes up, so does the other, because this is positive, okay? So in this case here, I can go ahead and reject my null hypothesis. And again, they use a two-tailed test because they weren't sure. Maybe it was going to be a negative value. Maybe as the fatty acid content goes up, insulin sensitivity might have gone down. They weren't sure. That's why they wanted to look at it and use a two-tailed test. But again, it does not include 0, so I already know it's going to be less than 0.05. And sure enough, you get it, and the p-value is 0.0021. So there's definitely a correlation here, right? There's definitely a correlation, but that does not mean that one directly influences the other, right? This is useful to helping to generate future hypotheses. It's not useful to determine anything specifically from this, okay? Again, I'm rejecting the null hypothesis that I would find results like this extreme or more so, very unlikely, like less than 0.2% of the time, or about 0.21% of the time. So again, we can reject that null hypothesis. So let's talk about correlation and causation, right? Because causation is the important thing we care about. If I do this to my patient, then this is going to happen. That's what I'd like to know. So again, you can try to figure out, like, why did these two variables correlate so well? So there's a couple questions you can ask yourself. Well, does the lipid content of the membranes determine insulin sensitivity? Maybe they covary with one another, so maybe one directly influences the other, or maybe the insulin sensitivity is somehow affecting the lipid content. Maybe it's the other way around, right? When you're doing these correlation evaluations here, you can flip X and Y. It doesn't really matter. You're going to get the same results here. When you're doing correlation, because you're not really worried about causation at that point. So that's another thing I want to mention there. Now, could it be the insulin sensitivity and lipid content under the control of some other factor? Perhaps there's a hormone that happened to be affecting both of these? Maybe. Or, lipid content, insulin sensitivity, and other factors are part of a complex network of feedback. And we're just getting a glimpse into something that's much more complicated. Quite possibly, and very likely, to be honest. So just because the two variables, or I guess we could look at the whole population and find that the two variables don't correlate at all, and what we found was just a coincidence. Perhaps it was a type 1 error that we rejected that null hypothesis and we shouldn't have. Maybe we just had some bad data we were working off of. So the point is that we need to do more research to find that answer there. It's useful to know there's a correlation, but again, it doesn't really help us out in terms of making like clinical decisions, right? So as I mentioned, correlation does not necessarily imply simple causality. You can find that two variables can correlate with one another very well without having any degree of direct causation. So for example, if you were to look, and maybe not, this is not the case nowadays, but if you were to look at the number of telephones per capita, or maybe the number of cell phones in use, and life expectancy, you'd probably see a correlation there, because that would probably imply some degree of wealth in an area and maybe increased life expectancy, right? But of course, there's always assumptions we're looking at when doing these type of tests here. Again, we're assuming it's going to be a random sample we're dealing with, making sure that we're dealing with paired samples. In this case here, that the insulin sensitivity for one individual was matched to the fatty acid content of the same individual, right? So making sure that the sample is actually paired there to find that relationship. Make sure we're only going from one population, however we define it. And there's independent observations. You're not using like siblings, and you're not doing the same person twice. They could influence the results there. Note that the X values cannot be used to compute Y values, right? So again, that way you make sure that the actual values themselves are independent of one another when trying to look for that correlation. Because otherwise, if you use one to calculate the other, then there's more likely to find something. The X values were not experimentally controlled. Again, we were just observing. We didn't actually have any direct intervention here. We're just plotting. We just measured it and plotted it against the two variables there. We're going to assume follows a normal distribution and that the covariation is linear, right? So again, we're trying to keep it simple. We're not assuming that there's any kind of curve to this. Okay, the covariation is linear. We're going to, we talk about like linear regression. That'll be an important thing there as well. And of course, no outliers, which kind of follows along with the normal distribution. Now, importantly, there's going to be something called R squared, and this is going to be useful as well. And typically, it's just the R value squared, pretty easy. So instead of having positive and negative values, R squared is always going to be between 0 and 1. And so you're going to see that used pretty frequently, and this will come up when we talk about our the amount of variance shared between two variables. How much, if one goes up, the other one goes up. You know, that relationship can vary, and that's what R squared is going to help us out with. And that's what we're going to look at in one of the next lecture sets here, okay? And again, correlation is used sort of the statistical meaning, quantifying the association between the two variables, right? Again, they're continuous variables too. You couldn't really do as ordinal or nominal variables here. And again, correlations, it's kind of a general term you hear a lot of people use here, but specifically, this is what we're talking about, our R values and whatnot. If you ever hear a coefficient of determination, that's just a fancy term for the R squared value, which I guess we put a little caret there or something. We normally just call R squared. Okay. So just a few Q&As, just make sure you kind of test your knowledge of the subject. Can a t-test be computed from the mean, standard deviation, and sample size of a group? Yeah, absolutely. Like, you don't actually need the raw data, nor will you be given the raw data in a lot of journals. Again, you could calculate it yourself if provided, at least with those three things there. Why is it called an unpaired t-test? Well, it's because you're using the values of two groups that have no relationship to one another, okay? Not using siblings, not using the same person multiple times, all those things there, okay? Does it matter whether the two groups have different numbers of observations? No, you can find that the groups can be a little different. If you have extreme differences between the two groups, maybe like one has 10 and the other one has like 100, you're more likely to run into some errors there in terms of like violating Gaussian assumptions. And again, if you're using a t-test, that's called a parametric test, you're working with normally distributed or Gaussian distributions. Okay, that's an important thing to consider there. Let's see, can I decide how subjects are matched after collecting the data? No. Again, when you're pairing data and things like this, you have to figure that out a priori or before the experiment ever begins. If you try to do this after the fact, now you're going to compare groups together, you're just running into the multiple comparisons problem, which is not sound science, right? So you don't want to do that. In the case of looking for correlation, does it matter which variable is called X and which is Y? No, this will matter though when we get to looking at actual like linear regressions and talking about things like that. So X and Y will be important there. Here with correlation, it does not matter. I could have put the insulin sensitivity on the X-axis and really wouldn't made a big difference. Okay. Can R be negative? Yes, because you can have values that increase on the X-axis but go down on the Y-axis, and so you can see that would be a negative correlation in that case there, and so the R value would be negative. R squared is always going to be between 0 and 1, so that'll never be negative, okay? Because a negative value squared is going to be positive. And so if you double the number of points, but R doesn't change, what happens to the confidence interval and the p-value, right? So let's say instead of like 13 men I did that study with, I did it with, say, 100. So a lot more points there. Typically, your confidence interval is going to get more narrow, and your p-value is going to get lower, typically, okay? Assuming that extra, 87 people in there were not, extremely variable or something like that. Skew the data. Okay, so any questions on that PowerPoint while I get set up for the next one? Oh, here's some questions. All right, let me switch over to this. Someone asked, do you provide an outline of the most important topics to study for the test? My PowerPoints are pretty good at outlining the points. I think during the review, you'll have a better idea for things to look at in terms of like importance. Again, a lot of the first test is going to be knowing your definitions, knowing some kind of the broad concepts we're talking about, and then interpretation. So for instance, if I were to give you a vignette where I say, okay, well, the odds ratio was 0.45 and the confidence interval was between 0.3 and 0.6. What can you determine about these results? And you could easily say that these results are statistically significant because an odds ratio, if the confidence interval does not include 0, then, or does not include 1, then it is statistically significant, right? If it was like an absolute risk reduction, that included 0, then you'd say, okay, well, this is not statistically significant. I cannot reject the null hypothesis, right? Knowing definitions like what's a type 1 error versus a type 2 error, things like that. So I think those are kind of the main type of questions I ask on that first test there. I'm not sure even when the test is, to be honest. Look. Our first test is, we got Farm on Monday. My goodness, coming up quick. And then, wow, we don't have, Epi Bio is not until, what's exam 1? Where's, oh, okay, it's gonna be on the 9th of October. So we got some time for that one, so we got some time there. Okay, we asked questions about specific examples on your test, such as the firefighters or AZT HIV experiment that we need to remember, or do we just need to know the concepts that the examples demonstrate? Know the concepts that this demonstrates. I'm not going to ask you specific questions or even like numbers from this test here. I will for sure ask questions that might pull from those concepts. I might give you a vignette that is maybe similar in study design, but I'll give you all the data, I'll give you all the numbers and whatnot there. Okay, and again, the review will be very helpful in giving you some ideas of what type of questions we're going to ask. I know this could be like anxiety inducing. I think most people worry about this test because they fear the unknown more so than the difficulty of the topic. I think a lot of people kind of get intimidated by this stuff, and I understand that. Don't worry, I get it. I was intimidated by this stuff when I was in school too. This stuff was like complete gibberish to me at first. And I had like an actual like biostatistician teaching us, and so it was just like way past our heads. I'm trying to make this stuff practical to your purposes, right? So that way when you see something like an odds ratio being expressed, you know what that means. You know what the heck they're talking about versus an absolute risk reduction or a number needed to treat, things like that. I'm trying to keep it practical, right? So anyway, so wait for the review. You'll see some examples of what we're talking about here. Okay, it'll make more sense. So I uploaded some more of the PowerPoints up on Canvas. So I'm going to go ahead and get started on Module 7 here just because I want to keep on track. It's funny, I got a lot of likes on my last one, not so many likes on this one. Pretty telling, I think. I'm just kidding, I don't mind. I'm not here for the likes, I'm here for the knowledge I get to share. Anywho, let's talk about fitting models to data. So now we get to use some models here. I'm not talking about the kind that walk down the catwalk. I'm talking about the kind that looks our pity. No, I don't want your pity likes. How dare you? You take back your pity likes. I don't want them. No. So anyway, a lot of times what's kind of interesting is when, for instance, like use models all the time. Like for instance, like when we use like the Cockcroft-Gault equation to determine a patient's GFR based off of their serum creatinine. That's a model, right? Like we had to do an experiment with people to figure out like what the right equation is necessary in order to come up with a creatinine clearance that is accurate and reproducible. That's a model, right? That had to be done with an experiment. This is what I want to talk about here is how we can actually look at things like causation and correlations and whatnot. Oh my goodness, I did it again. It's okay, I'm still on the first slide. It doesn't matter. So anyway, I'm going to do that like once a lecture just to drive you guys crazy, I think now. But anyway, so what we're going to look at are going to be things like regressions that kind of help us to determine how much of one variable can be predicted by another variable, right? And so there's going to be simple regressions, there's multiple regressions. We're going to get into some of those details. This is where it's really easy to get kind of like outside of our scope. So I'm going to try to keep it sort of to the basics in terms of what you're going to see frequently in the medical literature, okay? So basically, if I was to do a linear regression, what it's telling me is like, what's the line that best fits the data that I'm collecting when I'm comparing two different variables to one another, right? So basically, it's like a best fit line. We're going to use our y equals mx plus b, if you remember that from your maybe your geometry classes or maybe some basic trig stuff or something like that. What we're going to do is use the slope of a line to help us predict if x is this value, what is y going to be, okay? So we're making predictions here, and using that line, it can help us to make as good of a prediction as possible. So we're going to use the slope and the intercept to help us out with that. So let's go back to our insulin sensitivity data, right? So we just talked about that, so it should be fresh in your minds here. Remember, our two variables were going to be on the x-axis, we had the fraction of fatty acids, and then on the y-axis, we had the insulin sensitivity. And we got a best fit line on that. Remember that we had that correlation or covariation line that we were able to generate there, right? And we saw that it was a positive correlation between the two. So we could say as percentage of C20 to 22 goes up, so does the insulin sensitivity, okay? And we can actually put that into our equation for a line, right? So y equals mx plus b. In this case here, insulin sensitivity is our value on the y-axis. We can figure out what our intercept is by looking at the graph, and then we can figure out what our slope is based off of the value of x, okay? So these are the two things we want to figure out by plotting x versus y, right? So we're kind of starting out with these two known variables, and based off of that, we can generate what our intercept and our slope is going to be, okay? Now, this is not necessarily going to account for random variation. So again, this has to go with how good your data is to start with. That's what we want to figure out there. So obviously, the better the data you're starting with, the better the line you're going to get, and how relatable it's going to be, or how much you can extrapolate that to a larger population. Because that's what you care about, right? You do a data set with a small sample, and then you can extrapolate that out to the larger population. You want that to be an accurate extrapolation, right? And again, we're assuming we're going with the Gaussian distribution here. So we want to find the values for the intercept and the slope that are most likely to be correct and quantify the imprecision with confidence intervals, right? So we're going to give ourselves a best fit line, and we're going to say, okay, well, what's the wiggle room here? What's the 95% confidence interval, which we think this real line is actually going to fit in when compared to the grander population, right? And so again, we're thinking about the model graphically. I'm going to show you here in just a moment here. And basically, this is the best thing that I can kind of explain it here is that the linear regression finds the line that best predicts y from x. So this absolutely matters which is on the x-axis and which is on the y-axis, okay? So what's the best line that predicts the value of y based on a value of x? If I measure x in a patient, what am I predicting their y value is going to be, okay? If I measure their blood pressure, what is their risk of death going to be? Now, whatever the case may be, the two variables you can figure out. Again, it's considering those vertical distances between the points from that line there. So let's say we were to look at that data again. We're looking at the percentage of those fatty acids there plotted here against the insulin sensitivity. So this data is the same as before with that line there, right? This is our line of covariation between the two there. And so we're giving ourselves some confidence intervals here to say, okay, well, the actual line could be something else, right? The line could be going, say, from the top of this confidence interval down all the way to the bottom here, and vice versa. It's somewhere in the middle there, right? So, but this is the best fit line based off the data that we actually have. And so we're saying, okay, well, if I predict, so if someone had a fatty acid content percentage of 20, what is most likely their value of y going to be? So I could say, okay, well, it's probably somewhere between maybe like 250, 275, something like that, okay? This is what we're trying to do with these linear regressions. And so you can get a whole bunch of values here. Again, this is all calculated in the stats programs. Don't get too worried about this stuff, but this is just basically giving you the idea of one, what the slope is going to be, what the intercept is going to be, right? And then it can also help you with stuff like the goodness of fit. And so when I talk about the R-square value, that tells us how much of y is predicted by changes in x. And I'll go into more details on that in a second, but that's the things you want to know. But the R-square value, the intercept, and the slope, and you figure that out. And of course, the confidence intervals here will help you to determine, if I were to extrapolate this out to the population, where that line's going to fit in between, right? So the slope here we figured out was 37.21 plus or minus 9.269, right? And so that best fit value of the slope is 37.2. When that percentage of fatty acid increased by 1, then the average insulin sensitivity is expected to increase by 37.2. Now again, if I were to extrapolate that at the population, would that definitely hold up? Maybe, maybe not though. That's why I have the confidence intervals there that range anywhere between say 16.7 to almost 60 and whatnot. Notice here that it doesn't include 0, right? Again, if that line of covariation does not include 0 with the confidence intervals, then I can say I can reject that null hypothesis that says that there's no predictability here. I cannot use x to predict y. I cannot use your shoe size to predict your IQ, right? There's no relationship between those two, at least as far as I know. I don't think there is. The intercept, though, so when x equals 0, where does that point hit on y? Can be defined both by the slope and the y-intercept there. And again, is that value of what happens if that C 20 to 22% equals 0? Like, what would the insulin sensitivity be? In a lot of situations, though, this is not physiologically relevant because this may not be like an actual value. Like, you couldn't look at a patient's systolic blood pressure versus their, I don't know, I'm trying to think, heart rate or something like that, and look at it and see like, okay, well, if the pressure is 0, then what would the heart rate be? Well, that doesn't make sense because your patient's dead at that point. So yeah, they both be 0, right? So again, doesn't always have to be physiologically plausible when you're looking at the intercept, but you still have to figure it out in order to get your slope and all that good stuff there, okay? Anyway, so looking at the graphical results there, we get that best fit line. It's going to let us determine that relationship to say, okay, well, if x is this, then what is y going to be? And notice here that even though the data can have some scatter, even if the data points are outside of the confidence intervals, that's fine, right? Really just we're looking for that best fit line and the confidence intervals around that line specifically, not the data points. If you were to look at this, you can see where the actual best fit line could be anywhere between this one here to this one here. And any of these could be correct. Anything in between could be correct if you were to apply that back to the population. I'd be 95% confident that the real line would be between here and here, okay? That's what's telling you. Even if the data points fall outside of that, that's totally fine. I don't care. The best fit line is what I really care about in those situations. So we also can get that R-squared value. So this is an important one too, right? So the 0.5929, this basically means that 59% of all the variance in insulin can be accounted for by the linear regression model, okay? This is an important concept because that means there's still 41% that is being accounted for by other factors. So this could be biological variation. It could be another variable. It could be a lot of other things. This is important to know because the closer this is to 1, the closer you can say that, yeah, this is the only variable I need to know in order to calculate, in order to predict someone's insulin sensitivity in this case here. Or imagine if you were to like look at the Cockcroft-Gault equation and you just use serum creatinine as a predictor of creatinine clearance. Well, that wouldn't take into account things like age. It wouldn't take into account things like patient's gender. It wouldn't take into account patient's weight, which we know are variables that definitely impact that. So sometimes a simple linear regression where you're using 2 variables, one to predict the other, may not tell the full story. And that's why R-squared is really important because it tells us how much of the story is being told by this one correlation here. In this case, it's only 59%. The higher this value is, closer to 1 it is, the better off we're going to be because this is more predictive, okay? Again, the p-value is going to be significant here because it tells us, the null hypothesis being that there's no predictability here. There's no relationship between x to y. In that case there, the r value would be, or r-squared would be 0 if the null hypothesis were true. And so since it does not include 0, then we can go ahead and reject that, okay? So tiny p-value means we can reject the null hypothesis. And so it lends a support that, yeah, there probably is some degree of predictability here. I could probably apply this to a population and get some correct predictions. So correlation and linear regression are definitely related. The null hypothesis for correlation is that there's no correlation between the two. And in that case there, if we were to do a linear regression, or when I'm doing a linear regression, the null hypothesis is that the line is straight across. The line is 0 basically, has 0 slope because there's no predictability between x to y, okay? So practically the 2 null hypotheses are equivalent even though they're slightly different in textual form, right? But basically if your r value is 0 and it's a straight line across, it means there's no predictability between x and y, right? Versus if it was perfectly 1 or perfectly -1, then there's perfect predictability there, okay? And so in this case here, p-values are identical between the two. It doesn't matter if you're just doing simple correlation or linear regression here, okay? So there's some assumptions to make with these. One, the model is correct. However, not all relationships are linear, right? This is taking a very basic sort of view of things, and there could be non-linear relationships that you have to take into account, right? And again, you may not be the ones that are figuring this out, but when you're reading the articles, you can have some idea of what they're talking about. They say, oh, we did a simple linear regression, or we did multiple regression. You're going to know what that means in the future. And so it also assumes that any value of x that model can predict the y value, and that may be a false assumption depending on kind of what variables you're looking at and the biological plausibility and stuff like that. And again, it should work if the assumption is made that the relationship between x and y is linear with a defined range of x values. And again, usually that range of x values is going to be something that's physiologically makes sense, right? Not using like a blood pressure of 0. So we also assume the data is normally distributed. We assume the data of scatter is normally distributed, so that means there's no outliers there. And that the variability stays the same between low values and high values. That should be the same as well. Data points should be independent from one another. And then here we're going to see the x and y values are not intertwined, meaning you don't calculate the y value from x, just like we talked about before. And x value should be known precisely, so it should be measured correctly. So these are just things we assume when we're looking at these linear regressions. And if violated, could lead to some of these type 1 errors we're talking about. Now let's compare linear regression versus correlation. Okay, correlation just quantifies to the degree that 2 of them are related, right? It does not necessarily fit a line specifically, but it tells us sort of the extent in the direction that one tends to vary with the other. So as x goes up, does y go up or does it go down? We're just looking at the degree to which those two tend to vary with one another. We don't have to think about cause and effect. It doesn't matter which one's x or which one's y. With linear regression, now we have to think about cause and effect. We have to think, okay, well, which one are we trying to predict from what? Because you may get different results. In this case here, we're thinking that the fatty acid content of those cells affects insulin sensitivity. So we're predicting y from x. So what we set as x and what we set as y is really important there, okay? So lipid content has to be x because we're trying to predict what y is, which is insulin sensitivity. If you flip it around, then you get different results. And so, as I mentioned with linear regression, that just means that the relationship between the two variables, or the variable and the outcome, is going to be a linear relationship. Okay, so just saying there's not going to be some kind of curve to it, which gets kind of outside of our scope. It's a simplified view, but it helps to make it practical for most purposes. And then when we're comparing simple versus multiple linear regression, simple just means we're looking at two variables, x, in the relationship to y. What we're going to find is when we do multiple regression, then we're going to look at trying to predict y based off of two or more x variables. So multiple regressions means multiple x variables, still trying to figure out one y value. Okay. So I'm kind of dying here a little bit in terms of voice, and I'm not too far off of where I need to be in terms of schedule. So I'm going to go ahead and cut off early. I hope you guys are not going to be too devastated if I do so. You can mark me off of my evals if you don't feel like you got your time's worth with me. But I think 3 hours is pushing 4 hours is quite enough. So let's see if there's any questions. I already asked that one. I don't see anything up on the board. You guys' brains are probably stirring right now. All 20 of you, thank you for joining me and sticking with me. I'm going to take your pity likes and put them on my shelf and adore them. Thank you for that. Yeah, thanks for joining me. If you have any questions in the meantime, feel free to email me. Otherwise, I will see you all next time, which is going to be on, I think, Friday. Yeah, so I'm going to record that Kahoot review tomorrow, and then I'll post it up for you guys after the fact on Friday. So you guys can watch that Friday night if you want. There won't be a delay. Sorry for the quick turnaround time between farm tests. It's not preferred, but sometimes you got to deal with the schedule. It is what it is sometimes. Some people are pregnant. Some people have to go on maternity leave. Some people, have deaths in the family. So stuff happens. I don't know. It just happened to be 2 weeks this time. But thank you for joining me, and I will see you all on Friday. Have a great day.